Good morning. Since you're postgraduates, I won't simplify this the way I would for an undergraduate batch. I expect you to think in terms of mechanisms, genetics, and pharmacokinetic pharmacodynamic, PK/PD principles, because that's what will guide your prescribing decisions in the wards. Let's begin with the fundamental classification of antibiotic resistance, as described in Jowett's and in an Anthanarayan. 1. Types of antibiotic resistance. 1. Intrinsic, natural resistance. Intrinsic resistance is an inherent, chromosomally encoded characteristic of a bacterial species, present in all strains of that species, independent of prior antibiotic exposure, and predictable before you even run a culture. Classic textbook examples you must know. Gram-negative bacteria are intrinsically resistant to vancomycin because their outer membrane prevents the drug, a large glycopeptide molecule, from reaching its target, the peptidoglycan layer, in the periplasmic space. Klebsiella species are intrinsically resistant to ampicillin due to constitutive production of a chromosomal beta-lactamase. Anaerobes are intrinsically resistant to aminoglycosides because uptake of these drugs requires an oxygen-dependent transport mechanism across the bacterial membrane. Mycoplasma species are intrinsically resistant to all beta-lactams and glycopeptides simply because they lack a cell wall. There is no target. The clinical implication: intrinsic resistance is predictable. It should inform your empirical choice before you ever see a sensitivity report. 2. Acquired resistance. This is resistance that develops in a previously susceptible strain. Goodman and Gilman's classifies the genetic basis into two broad mechanisms. A. Mutation, vertical gene transfer. Spontaneous chromosomal mutations arise at a low but definable frequency. Under antibiotic selection pressure, susceptible organisms are eliminated, while the resistant mutant is selected and allowed to proliferate. This is the principle of selective pressure, not induction. The antibiotic does not cause the mutation. It selects for a pre-existing resistant subpopulation. Example: rifampicin monotherapy in TB rapidly selects for RPOB gene mutants, which is precisely why we never use rifampicin alone. B. Horizontal gene transfer, HGT. This is far more clinically significant because it allows rapid inter- and intraspecies spread of resistance genes, typically carried on mobile genetic elements, plasmids, transposons, and integrons. 3 mechanisms as described in Jowett's: conjugation, direct transfer via plasmids through a sex pilus. For example, transfer of ESBL genes among Enterobacteriaceae. Transformation, uptake of free DNA from the environment, classically described in Streptococcus pneumonia. Penicillin resistance via altered PBPs. Transduction, transfer via bacteriophages, important in Staphylococcus aureus, for example. Methicillin resistance mechanisms. Biochemical mechanisms of acquired resistance. You must be able to list these on your exam. Enzymatic drug inactivation, beta-lactamases, aminoglycoside modifying enzymes. Altered target site, PBP2A in MRSA, altered DNA gyrase and fluoroquinolone resistance. Decreased permeability/porin loss, common in Pseudomonas and Acinetobacter. Efflux pump overexpression, tetracycline resistance, fluoroquinolone resistance, bypass/metabolic pathway alteration, sulfonamide resistance via alternate folate pathway enzymes. 2. Broad-spectrum versus narrow-spectrum antibiotics. From a pharmacological standpoint, as Goodman and Gilman frames it, spectrum refers to the range of microbial species against which an agent is active. Narrow-spectrum agents act in a limited range. For example, penicillin G against gram-positive cocci, or isoniazid against mycobacteria specifically. Broad-spectrum agents, For example, third-generation cephalosporins, carbapenems, fluoroquinolones, act against both gram-positive and gram-negative organisms, and sometimes atypicals. The pharmacodynamic trade-off you must understand. Broad-spectrum agents exert collateral damage on commensal flora, disrupting colonization resistance in the gut and respiratory tract. This selective pressure on the entire microbiome, not just the pathogen, is now recognized as a major driver of nosocomial-resistant organisms and C. difficile infection. This is emphasized heavily in Kushers as a stewardship principle. 3. Empirical versus definitive therapy. This is core clinical pharmacology, and it's tested constantly in postgraduate exams. Empirical therapy is initiated based on clinical judgment before the causative organism is identified, guided by most probable pathogens for that site of infection, local antibiogram/hospital resistant surveillance data, severity of illness, sepsis mandates immediate broad coverage, time is tissue, as in the Surviving Sepsis Campaign guidelines, patient-specific factors, immune status, recent antibiotic exposure, comorbidities, allergies. Definitive, targeted therapy follows once culture and sensitivity results are available, allowing pathogen-directed, narrow-spectrum, and often lower toxicity therapy. 4. De-escalation. This is the pivotal antimicrobial stewardship concept, formally endorsed by IDSA/SHEA guidelines and covered extensively in Kushers. Definition: de-escalation is the practice of narrowing empirical broad-spectrum therapy to a pathogen-directed, narrow-spectrum regimen once culture, sensitivity, and clinical response data become available, typically at 48 to 72 hours. Rationale, as per stewardship literature, minimizes selective pressure driving, MDR organism emergence, preserves normal microbiota and colonization resistance, reduces drug toxicity, cost and risk of superinfection, notably C. difficile colitis, shortens unnecessary broad-spectrum exposure duration. Practical steps in de-escalation. Review culture/sensitivity report and clinical trajectory. Discontinue redundant or overlapping spectrum agents. Switch to the narrowest effective agent based on sensitivity. Convert IV to oral therapy where clinically appropriate. IV to oral switch. Reassess total duration. Stop therapy as soon as clinically indicated. Not by habit. Professor addresses the class directly. So here's the framework I want committed to memory. Intrinsic resistance is structural and predictable. Acquired resistance is dynamic and driven by mutation or horizontal gene transfer. Clinically, we start empirical, broad-spectrum therapy when the pathogen is unknown or the patient is critically ill. But the moment we have definitive microbiological data, our duty is to de-escalate. Every unnecessary day on a broad-spectrum agent is a day we are actively selecting for resistance in that patient and in the hospital ecosystem at large. That is the essence of antimicrobial stewardship, and it will define you as a rational prescriber. Longer. A key reason doses get adjusted in kidney disease. Together, these four processes determine a drug's concentration in the body over time, and that curve tells doctors how much to give, how often, and for how long. Pharmacodynamics. What the drug does to the body. This is about mechanism. How the drug actually produces its effect. Most drugs work by binding to a target, usually a receptor, enzyme, or channel, like a key fitting a lock. An agonist binds and activates the target, triggering a response. An antagonist binds but blocks the target, preventing the natural signal from getting through. Pharmacodynamics also explains the dose-response relationship. More drug generally means more effect, up to a point. Then you hit a plateau, or start seeing toxicity instead of benefit. This is where concepts like potency, how little drug you need, and efficacy, the maximum effect possible, come in. Here's the key insight. Pharmacokinetics determines how much drug reaches the target and for how long. Pharmacodynamics determines what happens once it gets there. A drug can have a perfect mechanism of action, but if it's absorbed poorly or cleared too fast, it won't work. Conversely, a drug that lingers too long because of slow metabolism can build up and become toxic, even if the mechanism itself is sound. So next time you take a pill, PK is the journey. Absorption, distribution, metabolism, excretion. PD is the destination. What actually happens at the molecular level once the drug arrives. Together, they're the foundation of how we dose medications safely and effectively. Thanks for listening, guys. Good morning.